much. So now we're going to go just into the discussion. Again, if anybody else in the audience has questions, and just going to throw out some questions to the group and hopefully have a lively discussion. So I'll start with Dr. Tedford. You know, the field is evolving so rapidly in options for managing patients outside of GDMT. We have CLIPS, we have these CCMs. Where do you see live therapy fitting in to this regimen? We know the class of patients, NYHA, 3, ambulatory 4, but where do you see this fitting in?
Yeah, Jen, it's a great question. I think it's that treatment gap that you described. Those patients that, despite all of our guideline-directed medical therapy, still are symptomatic, yet either are not candidates or are not quite sick enough for more advanced therapies. I think it'll be interesting to see, what the positive impacts are on this less invasive remodeling. Could we eventually see that patients, even with more severe valvular disease, obviously excluded from this study, could benefit from a therapy like this? And so, it's an exciting time to be in the field. We have lots of different devices that may theoretically help this group, but I think it's a major unmet need, and I think time will tell about, how exactly this therapy fits in.
Okay, thank you. Dr. Klein, we know the target really is that LV aneurysm. When we're looking at these 3D CTs and the MRIs of the patient, what are the other things that are going through your mind from an anatomical standpoint when you're considering a patient? The LVH, RV function. Can you just kind of walk us through your thoughts on evaluating patients for life?
Yeah. So, importantly, I think the aneurysms constitute a subset of the remodeled patients, but I think there's also a large group that, as I said, it's not really aneurysmatic, but are globally dilated, but there is adequate scar in the anterior wall and or septum. So that's one. I think in looking, we always evaluate, of course, right ventricular function, pulmonary arterial hypertension as potential enlarged risk factors. And there are multiple technical ways to reconstruct the ventricle. Optimally, we would use the internal and external anchors to take out as much of the septum as we can and go on the border of the scar nearing the lateral wall. Sometimes we think because the ventricular function is so poor, pulmonary arterial hypertension is so severe, RV function is diminished, we tend to use a more surgical way to reconstruct the ventricle, so it's in very high-risk patients. That's in consideration. Scar delineation scar location is very much important, and these very globally dilated ventricles, they're really, really large. that is making a reconstruction technically a bit more difficult in the extremes. So we tend to look at pulmonary hypertension, right ventricular function, scar extension, global dilatation, of course, valvular function. So these are considerations in general.
Excellent. Dr. Puri, mitral regurgitation, significant mitral regurgitation is one of the contraindications for enrollment in the ALIVE trial. Can you just touch on that, explain, the interlinking here between this therapy and MR and remodeling?
Yes, we know, at least 20% of the HFrEF patients in HFrEF has, a variety of etiologies will have secondary or functional MR. And so, obviously with the apical scar and adverse remodeling, you can certainly get tethering of the mitral valve leaflets and you can get secondary MR. And so, but sometimes, we've seen that when you apply this therapy to these patients, even though severe MR is contraindicated, in those patients with less than severe MR, you can certainly sometimes see some improvements. So, it begs the question that once this therapy starts to become more expanded outside of the tight constraints of a pivotal trial, and certainly Patrick has a lot of experience along with some of his European colleagues, you can certainly start to sort of see some of the important changes that can occur in a subset of patients with MR.
And I'm just going to open this up for the group, as we learn from the surgical door procedures, you know, and as heart failure specialists, we really appreciate that septum, right? The contractility of the septum as it relates to RV function and just a general, the LVkinesis. Part of the revascularization for the door was, you know, making sure there was perfusion to the septal perforator. Any thoughts on how that could apply when you're looking at the angiograms for these patients, looking at their imaging as far as where the stenoses are in their vessels, and how you can apply that knowledge that we learned from the surgical literature to this?
Is that to me?
Anybody?
Yeah, I mean, I think, you know, when we do primary PCI, you know, we want to get the major epicardial vessels open. That's our primary goal, to restore prompt and timely reperfusion. Sometimes you do get sludge, thrombus, plaque shift down the septals. Typically, we don't chase septals. Some people do. It's controversial. Sometimes keeping it simple and keeping your focus on the main game is going to be better for the patient and for the intervention. And so, you know, it's intriguing. I mean, we block septals for HOCM and in other structural heart procedures to, for example, prevent LVOT obstruction when we do transcatheter mitral valve replacement. And so you can apply two different kinds of therapies to the septal vessels. But typically, you know, I mean, these ventricles are typically way beyond help using conventional therapies. And so if you're knocking off small septals mid to distal wall with the aim of remodeling the ventricle after your therapy, it probably is of less rather than more concern.
Dr. Calgar, I'm glad you mentioned the right ventricle, of course. I was curious for Dr. Perry and Dr. Klein, do you have any information you could share about what is happening to the right ventricle with more longer-term follow-up? Are we seeing improvements in septal function with the LV size reduction?
I think we didn't really study the right ventricle per se. I think you don't see deterioration. I mean, so what we did do is study diastolic dysfunction after this procedure, as measured by echo. And interesting is to see that our worries were also with the surgical ventricular reconstruction, that you induce an amount of diastolic dysfunction. And what we see here with the live procedure is that this diastolic dysfunction is not happening. So there is an increase in contractility, but it's not at the expense of diastolic dysfunction. So you don't, in our experience, we don't really see a deterioration of RV function over time.
Interesting. All right. This is another general question, and you know, maybe especially to Dr. Perry, who did our imaging talk. You know, the imaging software and technology has just evolved light years since I was a fellow. Is there a way to use some of this software to predict how well the LV will function after your ventricle? Basically, to just, you know, do some modeling to see if the LV, the dynamics potential for excluding that scar area.
Yeah, it's a great question. I mean, the simple answer is we don't know yet. It's all there to be done. I think the first step is to validate the methodology, which is what we're doing. We need to increase our sample size. We need to look at more normal hearts to understand which of these segments using inward displacement, what's the normal range for each of these segments. We know the septum doesn't necessarily come in as much as the lateral wall. So what is a normal inward displacement for basal septal region as opposed to basal anterior or lateral wall? We still have to define that. We have some ideas about how to do that, but we're still in the process of defining that. But look, you know, there are some therapies, and you mentioned hydrogel. You know, it's kind of flown under the radar a little bit in this meeting. The gentleman sitting next to me led the pivotal trial a few years ago. That certainly, you know, in the context of a thoracotomy, a surgical procedure, there were some really intriguing outcomes from a functional perspective for the heart failure patient. Hydrogel implantation is now going to be a transcatheter solution. And so we can now apply potentially inward displacement and segmentalize the left ventricle and use that during a peri-procedural therapy to guide your hydrogel injections. So very intriguing. You can set up your procedure on the basis of these imaging modalities.
So Dr. Cohen is hiding, and I apologize because I couldn't see Dr. Cohen hiding down there. But can you tell us a little bit about the alginate hydrogel? concept. What's the basis? What's the physiology there? Just so that we get an understanding.
Well, it's another form of reshaping the ventricle. You basically create a thicker left ventricle and thereby change the physics of the heart. It's another way of using the Laplace law. Biventrix with the Revivent procedure is doing this, and the alginate approach can do that as well. In the AUGMENT-HF trial, we had improvements in exercise capacity measured with the gold standard of exercise testing with the peak VO2 assessment in a controlled study. So that was rather impressive to see, and I think the concept of the Laplace law simply works, and you now just need to apply it.
Excellent. Well, it is 3:45. Whew, COVID brain. It is 7:45. Actually 7:48. And that it tells us that we need to move forward to the rest of the meeting. But I think we take away from this is that there are all these wonderful, exciting therapies out there. And I would encourage each and every one of you, when you're in clinic with patients with cardiomyopathy and they're not thriving, I really think it's our duty to think about all these novel interventions to get patients feeling better and to get them living again with heart failure. So thank you for coming out, everybody.
Thanks.
Thank you.